When you walk into a new specialist's office while sick or exhausted, the first thing you are often handed is a blank paper clipboard. At that moment, you are expected to recall up to 10 years of complex surgical history, hereditary risks, and precise medication regimens entirely from memory. This is the first-mile failure of healthcare. It is the specific point where the connection between a patient's actual biology at home and the hospital's database breaks down. That 20-minute administrative delay represents a systemic failure, driving millions in lost throughput and delaying care across the multi-trillion-dollar healthcare system. This gap creates information asymmetry, an imbalance where the clinic lacks the patient's daily context. Front desk staff spend their days in a state of administrative bloat, manually transcribing handwritten notes into computers. Because this entry is manual, the data stays trapped locally. It leaves billion-dollar electronic health records, the digital filing systems like Epic or Cerner, completely siloed from one another. By the time the doctor enters the room, they are forced to make diagnostic guesses based on fragmented, rushed data rather than a complete longitudinal history. For years, the proposed solution has been forcing rival hospital networks to build complex IT integrations between their competing software. To bypass these legacy failures, the point of data entry must move. The patient acts as the sovereign courier, carrying their records directly between providers. This is the foundation of the Human Operating System, or HOS. Medical technology must accommodate human suffering and stress before it requests data. Look at this interface breakdown. To support chronic patients, the system uses clinical color taxonomies. Respiratory, cardiovascular, and neurological data points are instantly grouped by subconscious color cues, reducing the cognitive effort required to log symptoms. This accessible design extends to physical emergencies. The SOS protocol bypasses lock screens to broadcast voice instructions to bystanders while alerting emergency contacts. For emotional crises, Aura uses a specialized, compassionate deferral protocol. Traditional medical chatbots often respond to distress with robotic messages directing users to 911. Aura's AI is engineered to actively listen and validate pain before bridging the patient to a human counselor. By designing for these physical and cognitive limits at home, the HOS generates a structured medical record as a byproduct of safety, removing the burden of active data entry. When the patient returns to the clinic, the paper clipboard has been eliminated. Instead, patients generate a secure, ephemeral QR code on their device. Scanning this initiates a direct, encrypted tunnel to the clinic's terminal. Encrypted payloads instantly populate legacy systems, bypassing the need for complex API access. If a hospital's security policies block a digital transfer, the system generates a standardized OCR JSON printout, a document formatted specifically so clinic hardware can ingest the data without transcription errors. This patient-held bridge neutralizes the interoperability paradox, injecting pristine data into legacy systems without requiring a single IT overhaul from the hospital. For the clinic, the results are immediate. This digital intake protocol erases the standard 20-minute paperwork delay for every patient. Front desk staff stop acting as manual transcriptionists. They transition back into patient care coordinators, focusing on the peeking on the waiting room rather than the data on the page. Removing the friction of data entry eliminates the administrative bloat and reclaims the throughput lost to manual paperwork. The narrative shift is most visible in the exam room, the moment the physician walks through the door. The doctor begins the consult holding a structured, chronological history. They no longer spend the first 10 minutes extracting basic facts from an overwhelmed patient. Throughout this process, the patient maintains sovereignty over their records. The technology facilitates the exchange and then gets out of the way. Repairing the first mile returns time to the exam room, ensuring those limited clinical minutes are spent on human care rather than hospital billing.